So first of all, the most important objective is number one is to that you know how to recognize that the headache is serious. I'm sure every one of you has experienced headache sometimes in your life, and it's very common. So, but we need to see whether the headache for that episode is serious, that need urgent attention. Okay, and then objective would be to discuss this common primary, we call primary headaches, migraine chronic tension type, and cluster headache. And then I will quickly go through some secondary causes of headache. So 5 A's that should alert you that we should immediately arrange some urgent neuroimaging and or to admit the patient to hospital for further investigation. So the first is acutely severe, worst in my life. And also if any head injury, the headache comes, then it's serious. Second A is abnormal neurological examination. So impaired conscious level, impaired cognition, visual disturbance, diplopia, a weakness affecting one side, all this should alert you that the headache can be serious. Third A is associated with systemic clinical features. So obviously headache with fever, you need to think of CNS infection. Nausea, vomiting, also it could be signs of severe headache. Fourth is a new headache occurring in the older individuals, age, say older than 55. And last is wake you at night. If you lie supine and then the headache gets worse, then you need to sit up to relieve the headache. Then this suggests it may be raised intracranial pressure inside. Okay, so obviously most of you should know that a bleed inside your brain, it could be intracerebral, small vessel disease, a bleed with a deep hemorrhage. It can be subdural after a fall or head injury, and say in younger population, it can be subarachnoid, severe headache. It can mimic a CNS infection, even with neck stiffness or focal neurological deficit. So I just put an asterisk in this, although I highlight bleeding inside your brain commonly causes headache, but some rare form of ischemia can also cause some pain, such as carotid or vertebral artery dissection. So say after some trauma, then there will be pain in the head, and then with a stroke. Very rarely posterior circulation, say involving the brainstem or the thalamus, the patient may present as pain headache as well. So not all headache is related to hemorrhage. It can be ischemia as well. And also CNS infection, classical severe headache, neck pain, fever, with or without confusion. Okay, so bleeding acutely, CNS infection, it can be acute, can be over a few days, and if it's a TB, it can be 1 to 2 weeks lingering on. Brain tumor is usually over a few months, and as the brain tumor develop, initially it may wake you up at night. Okay, but during daytime, it doesn't affect you. It's possible. And that's another entity. It's rare. It's intracranial hypertension. It can be benign intracranial hypertension. But any cause of raised intracranial pressure will have headache. So in all this, with all these 5 A's, if you worry, you just play by the rule. You admit an urgent and order urgent neuroimaging. So I had once encounter a young man, 30-year-old, good past health with headache for 4 to 5 days, quite severe. Attended A&E at a hospital and was no admission. I was discharged with Panadol. But the headache persisted, and he was a relative to my colleague in ninth floor in the Department of Medicine. So I arranged an early follow-up. So the next week, I saw the patient. He was alert, well, denied any fever. So he came in and just routinely asked the nature of the headache. Did it wake you up at night? And the patient said yes. So I asked the second time, did it wake you up at night? The patient said yes, yes, yes. So then I explained, well, although you look well, and this headache is supine and wake you up at night, I need to admit you right now tonight. So it's a PM neurology clinic. So he was a bit shocked, but I said to play safe, I have to do it. So I admitted the patient. CT brain after hours was completely normal, and the urgent lumbar puncture was done, and the opening pressure was 50. Okay, grossly high opening pressure, and eventually turned out as a case of viral infection. Okay. Now, so the first slide, the 5 A's, you think if anybody share with you, I have headache, then you need to go through these 5 A's, okay? And if any A's comes up to be, wow, it defeats one of the A's, and you need to think seriously whether urgent admission, hospitalization with neuroimaging is needed. Okay, then if the headache becomes chronic, okay, if I see a new case, a young lady with a headache over the last 10 years, okay, then we need to think of these 3. Could it be migraine, or migraine, chronic tension type headache, or cluster headache? So migraine, I'm sure some of you in your class will have this problem. Although it's usually one side, actually 20, 30, or even 40% in some cases can be bilateral. And it's actually very severe. And it's pulsatile in nature. So it's faha in Cantonese, or danha. Okay, the patient can describe to you pulsatile, usually very severe. And if this is the first ever migraine attack, and no other attack before, first ever, is very severe, and because it's usually associated with nausea and vomiting. So very severe, worse in my life. Many times, the young patients will attend A&E and be admitted to hospital. Okay, so this is possible. Anyway, so if you do nothing for migraine, classical, it's usually it's minimal for 4 hours, and it should usually subside in 3 days, 72 hours, if you do nothing. Okay. And then 15%, 15% the patient may, before the headache happens, may have some aura. And commonly is official with a zigzag, fortification, specs. So you may see this rarely, it may be some numbness, very rarely, it may be aphasia for minutes, and then the headache comes. So nausea, vomiting is very common, and usually the patient prefers to stay inside a quiet and dark room. If exposed to light, exposed to noise, the headache seems to get worse. So migraine is for younger people, 10 to 40, female more common, and more often many times with a family history. And this is not the case for chronic tension type headache, nor cluster headache, but for migraine, it's very common. And as most of you are aware that many things can precipitate Say for lady, it can be menstruation, so it's a monthly migraine attack. For some, it's certain food, chocolate, increased stress. So many, actually medical students will have increased attack before, few months before exam. And after exam, it settles, okay? Strangely, sometimes it's a rest. So it's a holiday headache. Once the patient starts holiday, then the headache comes. Okay, this is not good. But this is not common, but it can happen. So for the precipitants will vary from individual. So you need to clarify. Okay, chronic type headache is less severe than migraine. It's usually both sides. So the patient will complain it's a coolgy, okay? And if you ask the patient to grade the severity, 10 is very severe, 0 is not severe. For chronic tension type headache, usually 4 or 3. For migraine, it's 8, 9, or 10. Okay. A duration can be long. It can be, let's say, from minutes to even days to 2 weeks. So by definition, if it's more than 2 weeks per month, then and with this kind of character of nagging headache, then it fits the chronic tension type headache definition. Many times associated with a depressive mood, some panic disorder, poor sleep, and muscle pain, fibromyalgia. Okay, again, it's a female more common. And for migraine, it's usually, it will grow out after you stop post-menopausal. But for tension type headache, it can continue well beyond menopause. Okay. And uncommon to have family history and precipitant stress. Well, cluster headache is very uncommon, very rare. But I do encounter cases now and then. And many times, say for this, the GP will misdiagnose this as a migraine because it is one side, okay? Same as migraine, one side it is very severe, okay? It can occur for few hours, okay? But then the problem with this cluster headache is it happens in a cluster. That means say for the coming 1 week to 2 weeks to 10 days or whatever, it's happened every day. Usually occur at night. It's a nocturnal headache, happen at night, in bouts, every night, in a cluster, and then disappear for a few months to a year or even few years. And then if this happened to a male, so note that it's different from migraine. Migraine is usually female, although we have some male, but for cluster headache, it's usually migraine. And the age is around this 20-ish of age, and a male. And then if the patient is smart enough, then he will explain that at night with the headache, I see some ptosis, eyelid drop. So it's a Horner syndrome with nasal stuffiness and tears coming. So it would be good for you if you think of this cluster headache, you ask whether there's 流鼻水啊、流眼水啊, okay, many autonomic manifestation with Horner syndrome as well. So you because actually this headache occur in cluster and then settle disappear for a long time. Once I see the patient, the patient will already tell no more, okay? It happened, say, a few weeks ago when I first had this headache for a week, and then I saw the GP, a GP referred me to see me, and then after seeing me, actually the headache is completely gone. So no need for any treatment. Okay, and then I'll take a history, and then I managed to ask whether similar headache occurred a few years back, and sometimes the patient said yes, it's almost happened yearly, and then it comes in a week, and then gone, disappear, and then comes back again. So this is cluster headache in a male, and a severe at night, one side severe. A migraine is a attack here and then gone, but it's maybe weekly, few times per month, and for this pattern, and no aura for cluster headache. Now, so if you encounter headache, you think of serious headache. The common is about bleed, CNS infection, tumor, or any other cause. It can be raised intracranial pressure. And then you think of it as a migraine, could it be a chronic a cluster headache? Now, actually, there are many or hundreds of ADX causes for headache. This list is not exhaustive, but I just want to highlight some for your reference. So it can be caffeine, coffee withdrawal headache. So if you drink coffee with caffeine every day, and then if you stop drinking that morning, you may feel some heaviness of the head or even pain. It may happen. Some patients actually with chronic tension type headache get analgesic every day, and then once stops, the headache comes back more severely. So this is a rebound because of analgesic abuse. So this happens. So if you had head injury, then you may suffer from this post-concussion headache, also associated with some dizziness, poor attention, memory lapse, post-concussion headache. It may last for months. Drugs. So common drugs like nitrate for ischemic heart disease, xylostazol, or for secondary stroke prevention, or alcohol, or rarely used for ischemic heart disease now. So you can ask about a drug history. Occipital neuralgia. Now you heard of trigeminal neuralgia, which I will talk later. Trigeminal neuralgia is usually some aberrant vessel touching the trigeminal nerve. Occipital neuralgia is also known as occipitus. So there's a nerve coming out, and if there is something, a bony, a small, tiny, bony outgrowth touching the nerve, it may cause neuralgia. So it's always at the same position, and if you ask the patient to use one finger, the patient can point to the exact location. Then this is occipital neuralgia. Okay, we can try NSAID or neuropathic pain medication, Lyrica, gabapentin, but eventually we may inject some steroid to relieve the pain. Giant cell arteritis is kind of an autoimmune with a high. So if one side headache occurs in the young, you think of migraine, but if it occurs in the elderly, above 60 years old, so remember giant cell arteritis is disease of the elderly, One side, they think, oh, it could be migraine, oh, but she is old. Then you need to think immediately you need to rule out giant cell arteritis, and you check the ESR. And then if it's an elderly with new onset pain, it will be safe. If you remember, 1A is age. Okay, new onset headache occurs in an elderly. You really need to think whether it would be safe to order neuroimaging. Okay. Gastroenteritis, if left untreated, it may cause a stroke or blindness, so you need to make early diagnosis and give steroid. After cancer crisis, the blood pressure shoots up. Usually, it should shoot up to very high. Many elderly said, "Oh, my blood pressure very high, causing headache." I said, "How high?" The patient said, "It's 145." Okay, then we reassure them it's unlikely to do this blood pressure. It's usually 180 or 200 more causing headache. Okay, conclusion. So if you withdraw blood, withdraw a CSF lot, and with a low intracranial pressure, then it will cause headache. So both a high intracranial pressure and low, both high and low can cause headache. So post-LP headache occurs in say 15 or 20, even 30%, depends how much CSF you withdraw. Okay, the more you can take, the more likelihood to have headache. So this is the reason why we need a bed rest. So it's pressure on the wound to reduce the leakage. So it's a bed rest for 4 to 6 hours. So it's not necessarily bed rest, but to go for toilet and put pressure and then wash and then come back and lie back again. Okay, to reduce the occurrence of post-LP headache. I mentioned this disease before, intracranial hypertension, usually in obese ladies, say with polycystic ovarian problem, and then with raised intracranial pressure, we have blood edema, and slight headache wake up at night. So there's this disease entity is a sporadic spontaneous low intracranial pressure, hypertension. So it's just the opposite. When you stand up, the headache is worse. So you need to lie flat. So if you ask about the nature of the headache, it's just the opposite to the supine headache. The patient needs to lie bed rest. Bed rest, no headache. Okay, so this is the opposite in nature. Cause is why suddenly a sporadic spontaneous drop in CSF, possibly leakage somewhere along the CNS, along the CSF pathway. Okay. Usually bed rest and IV fluid, non-cellular hydration, bed rest, it may resolve. Okay. The immune system inside brain thrombosis is like the DDT in the leg. So there's the DDT inside is the sinus thrombosis or the commonly sagittal sinus thrombosis. It will be patient headache, raised intracranial pressure, and they have a venous infarct as well. So it may present as a stroke. A stroke may look like it's being struck with a headache. Okay, then the stroke probably is more into the arterial distribution. Okay, especially into sinus thrombosis. Patient dehydration, infection, this may warn the risk of venous thrombosis. Vasculitis, so it's the blood vessels inside the brain is autoimmune vasculitis. The patient may develop many times they have headache. Okay, headache and with stroke. So the diagnosis is to have imaging of the artery with bleeding appearance. Bleeding appearance of the vessel. Especially if the headache is during, after, headache is not uncommon. So the headache can also be with it sometimes pain with lots of discharge. Gambling is also a disease of the elderly. If it occurs in a young person, if the wind blows into your face, pain, in lungs, then trigamma is usually low division. Okay, lower division. If it occurs in a young person, it is like brain. If it occurs in the elderly, then likely trigamma may not be good. If it's severe, then you do an imaging. If it confirms, you see something, apparent artery, small artery touching the trigeminal nerve. Then, if it's severe, refractory to medication, a surgical procedure may help decompress or just move away the decompress the trigeminal nerve. Okay, occurred in the upper part. I had a few years ago a saucer, it's reverse segmentation. It's very painful. It's with the pain, you just counts reverse without blistering lesion. So my experience, I experience pain around the eye. And initially I thought it would be glaucoma. So I went to see my ophthalmologist friend, immediately checked my blood pressure was normal. Okay. Then afterwards I noticed like pinhole. I don't know, but the small pain then it's really towards the pain onset, and there were blisters. What can come out blisters on the rather than annual opening. So we need take a severe and as well as total precaution or the control on the pain. TMA joint dysfunction is not commonly associated with anxiety disorder. Okay. The pain can be referred if the head, then the patient also has neck pain, and elderly, spondylosis, spinopathy, it may have pain also elsewhere. The common symptoms are the pain, toothache. Okay, and then last it can be other pain versus around the eye. It could be acute glaucoma, blurred painful eye, or neuritis. It's also blurred. It's more controllable. Pain, mechanism can give painful ophthalmoplegia. So it's how this is the low side is autoimmune, what makes tissue around with painful it's painful ophthalmoplegia. So the DNA is how people it can be multiple granular of the as well. So this is just a quick low side. We need the MRI and contrast and signal response of zero. Okay, just a quick word about the treatment of migraine first. Common sense, avoid precipitated factors and advise to stay in a quiet room. Okay, so the acute treatment is NSAIDs, ibuprofen or diclofenac, potassium NSAID, so NSAID is the first one. So the NSAID doesn't work, then we think treatment hospital authority is sumatriptans. The remark you need to take it shortly after onset of headache within 30 minutes. If some migraineurs, the headache comes, they will wait, they will try NSAID, and then after an hour or two, still painful, then try triptans. But if you take triptans long after the pain happens, more than 30 minutes, then triptans is not that effective. So from your past experience, you know that NSAID doesn't work. Don't waste time in trying NSAID. You just take triptan as a first line. Okay, there are other combinations of analgesics, which you can, if it's available, you can try. You can NSAID together with triptans. So it's usually the triptan is not complete abortion, then you try NSAID triptan together at the same time. In the old days, we have the ergot-related, we call ergotamine with caffeine. Nowadays, rarely used. Ergot compound has side effects like retroperitoneal, pulmonary pleural, or even valvular fibrosis. Okay, you use long term. So first line, actually, you try NSAID. If it doesn't work, you try triptans. If the patient has severe nausea and vomiting, you may give anti-emetics at the same time. Many times, because the vomiting is so severe that whenever you swallow the triptans or NSAID, you just vomit it back. So some migraines sufferers may need to attend A&E for injection of anti-nausea and vomiting drugs. After injection, less nausea and no vomiting, and then you swallow the triptans. Okay, now if the head migraine attack is quite disabling despite the acute treatment, so few times per month, then you can consider daily prophylactic preventive treatment. Okay. So the first line is still beta blocker. The oldest one we use is propranolol, but actually other propranolol, other beta blocker, metoprolol, twice or daily can be used. For propranolol is usually twice or 3 times daily. Okay, but remember this contraindication remarks of using all these drugs. So if you have asthma, heart failure, Raynaud, or heart block, depression, don't use beta blockers. So there are other, such as angiotensin II receptor, candesartan may help. Anticonvulsant topiramate may help. So for me, I will try beta blocker first. Okay. Second line. So it's tricyclic antidepressant. And so that this contraindications, even calcium antagonists and anticonvulsant, but note that have more side effects for this second line agent. Now we have this latest, we call the CGPM, calcitonin gene-related peptide monoclonal antibodies. Okay. So these are the latest. It's really kind of a target therapy, the pathomechanisms of migraine. So it's very expensive. It's a few thousand Hong Kong dollar per injection. Most of this first generation, you need to inject into abdomen. It's a pen-like injection, easily administered. It's a monthly injection. And it's very effective, I must say. Some actually can try botulinum toxin. You inject the Botox, not for wrinkles, around the forehead. And not apart from the pain, it will not be absorbed systematic to the blood system. Okay, just around the head, it's effective as well. But nowadays, I think the trend more severe, frequent migraine attack, refractory to first-line medication. Many will try this calcitonin gene-related peptide monoclonal antibodies. Okay. There are other things many patients in Hong Kong will try. Acupressure, acupuncture, relaxation hypnotherapy. I have no strong views or whatever. It's not too expensive, and if the patient finds it helpful, then it's okay. Okay. Well, last for chronic tension top headache, is kind of similar for migraine. Is we can try paracetamol. Aspirin. Actually, most of this drug, paracetamol, you can get off at the counter, so the patient usually try this before and doesn't help. So it's likely NSAID. Okay, you can give NSAID for during this so-called acute attack, but avoid long-term use. So you need to advise long-term use. It's many side effects, bleeding, also bleeding. It's no good. For preventive, it's less complicated than migraine. For migraine antidepressant, amitriptyline or SSRIs, so amitriptyline is a second line for migraine. But for chronic tension top headache, many of these patients, as I said before, also some depressive mood, insomnia. So I would give antidepressant amitriptyline. As they start with 10 milligram amitriptyline, may have some sleepiness, so it helps the patient sleep. And for the patient, but it takes a few weeks to start to work. So you need to advise the patient. Some patients need a bit more time to work. Chronic tension top headache. Okay, so that's a quick go through of headache. So, do you have any question? You type in your question anytime. Good. Now, if no, take 3 minutes break, and then we'll come back for the next lecture. Okay, around 11:06. Okay.